The session is about clinical trials, and it's led by Dr. Thuy and myself, both of whom have really based our careers around clinical trials and aging rapidly in the process. All right, so we sent you some questions before in advance of this. So these were the questions that I didn't get the answers from Joanna, so I don't know how you did with these. But so which of the following is always important in designing a clinical trial? And there's 5 things there. I don't know how we do a multiple choice with 5 things and 2 color answer cards, actually. Maybe we just do a vote with green cards again. Defining the exact characteristics of the trial participants. Who likes that one? Most important? It's always important. No? Deciding on only one outcome to measure? Including either an active or placebo control group? Well done, Annette. Rabble-rousing as usual. Just follow Annette. When her hand goes up, you must raise the arm. Doesn't matter which color. So including either an active or a placebo group, always important in designing a trial. Well done. Using an online sample size calculator to estimate sample size precisely. Who thinks that's always important? No. Taking time to consider thoroughly all alternative design parameters. Okay, so those are the things we think about. Now I'll go through how to design a clinical trial. The fastest ever, right? These are the principles, the things you have to think about. Then we might go back to the questions. So this is most of the things, most of the big things you have to think about in designing a clinical trial. You have to think about the aims, the overall design, study population, intervention, control group. Does this pointer work? Yeah. Okay. Control group outcomes, sample size, analysis plan, bearing in mind the whole time. Whatever you put in there, is it ethical, is it feasible, and is it financially viable? Okay, so we'll just go through each of those, the core principles. So first of all, the aims. So you're there, you're trying to design a trial. You thought of a good question. Now you're trying to design a trial for it. So you have to decide what's the question, and then you define the aims. And it's important to try and be as precise as possible. This is the key thing. This is the anchor for your trial. What's the aim? So if that's vague, the design's going to be all over the place. And what I find in design, trials are a long process. You keep coming, it's like a balloon, some bit pops out and you put it back in and like that. So the only anchor is the aim, right? So you keep coming back to the aim. So you've got to get that precise as possible at the beginning and write it down and always keep coming back to that. You may want to change it if it becomes infeasible. But that's key, defining the aim. So the question, the next one is what's the aim of your trial precisely? So the overall design, you've got all these choices, single arm or control arm trial. Hopefully by the end of this I'll have convinced you that doing single arm trials isn't necessarily the best thing. So parallel or crossover, that's when you're testing a control or 2 interventions. So parallel is where they continue all the way through the trial. Crossover is when patients flip. You're testing A versus B, and then the patients on A would flip to B, and the patients on B would flip to A. So you've got like 2 controls there. And then there's superiority versus non-inferiority, and then equivalence, which is a mixture of the 2, but that's a fairly important thing to decide. Are you trying to test superiority as your thing you're testing? You think it's better than the current thing that's normally done, or is it non-inferior? Then the phase, sometimes for investigators, unfortunately, the phases of trials are for pharma, right? So when we design our own investigator-initiated trials, they have different aims, and some of they don't necessarily fit into standard phases of trials. It's a pain because all regulatory agencies want you to declare what the phase is, and if you're trying to apply for funding from pharma, they want to know what the phase is. So you end up pigeonholing your trial into a phase, but it's kind of usually a meaningless concept when it comes to investigator-initiated trials, but we just have to do it. And phase 1 is usually healthy volunteers testing safety, toxicity. Phase 4 is post-licensing. Most of the trials you do as an investigator-initiated trial post-licensing would be phase 4, or if you're lucky enough to get millions of dollars, you might be able to do a phase 3, but that's unusual. So it's usually phase 4, or sometimes you can get an early compound, you could do phase 1. Unlikely. And then whether it's going to be randomized or not. Okay, so that's the overall design. You just like have a one sentence. This is a randomized parallel group superiority trial. Blah. Okay, pick word salad from that. So then intervention and control group. So with the intervention, you have to define your intervention. And again, what I find with teaching people to design trials, very often, oh, we're testing this drug, we give this drug. It's like, well, what dose? And for how long? And what else are you going to give it with? You have to define the whole package. It's not just give this drug, because the dose may make a huge difference to toxicity or to efficacy. So you have to define really the whole intervention, and what are you going to do with adherence? Are you just going to leave it to chance, or is everybody going to get adherence counseling? That's all part of the package that you would offer in a trial that you're testing. Or, for example, resistance testing, selection of drugs. Are you going to do that, or are you going to give it blind? All fundamental things for defining the intervention and the background of the intervention. And quite often it's good to think about things as a complex intervention. There might be, let's give this drug, but actually with this drug, we need to think about the whole other aspects of care. Essentially, it's a complex intervention that you're designing. Don't think of it too narrowly. But defining the intervention, really important. So there we go. That's intervention. Control group. So why do we need a control group? Hopefully, I don't need to convince you of that. But if you don't have a control group, you can't distinguish the effect of your new treatment or whatever you're testing against spontaneous improvement over time. If you take people when they're sick, they tend usually to get better. And so, it's hard to attribute what's to the drug and what's just spontaneous improvement. Regression to the mean. If you take a group that, ultimately they will get, the mean of the group will, the subjects will come back to the mean. And then a placebo effect of increased care and attention. When you put somebody in a clinical trial, they generally feel good. If you do the consent process properly, you tell them they're going to get special care and attention. They get to know you as a doctor or a researcher. And they feel generally better, and the placebo effect can be quite strong in clinical trials. People get better care. So you can use historical controls, but meaning you test this and then you compare it with what happened in your clinic last year when people were getting a different thing. But all sorts of things change simultaneously, and it's very hard to sort that out. So ideally, you want randomized control group. And the big advantage of randomization is it excludes selection bias. It means your clinicians can't pick and choose patients to go on each regimen. I do, when I give this to, similar talk to medical students, I show them an old study comparing, physician selection of an intervention versus randomized one. It was the Delta trial, an old trial. Showing completely different answers. So selection bias, and it was driven by selection bias. So selection bias is really can be quite powerful. So randomization gets rid of that. And the most important thing is it ensures your two groups are similar for everything except, or it should do, similar for everything except your intervention. So in technical terms, it gets rid of confounding, both known and unknown confounders, and it's the only way to do that. So randomization is critical for understanding and having confidence in the results of the trial. Okay, and the other advantage of randomization is it sounds really good. If you want to publish a study and you say it's a randomized controlled trial, that already you go up the impact factors of the journals immediately, right? So it sounds really great. So what is randomization? It's allocation by a purely chance process. It's not haphazard. It's like it's not a case of like I'll allocate this patient here and that patient, whatever you feel like at that moment. The key thing is the clinician should not be able to predict the allocation of the next participant, and usually it works like this. We have the statistician draw up a list of who's going to be, what sequence the randomization is going to occur, who's going to be allocated to which group. And then it can happen where you put those into envelopes, and then people at the sites would draw sequential envelopes. That's fine. There's all sorts of procedures to prevent cheating around that. So if you look at, people rarely do this these days, but you put the codes, and then you need to worry about people steaming open the envelopes or holding it up to the light to see what the thing is. So there's all sort of recommendation, putting silver foil cover the piece of paper inside with the randomization code, so you can't do that. But the best thing is you have a central coordinating center independent that holds this, and then the people who are actually seeing the patients and randomizing, they have to contact that third party who then tells them what the randomized allocation is, and then you're protected against any risk of cheating, or more importantly, any perception of cheating. You know, when you write up trials, when you try and convince people that you've got an answer which is meaningful, it's not just what you've done, but it's what you appear to have done. So if you can say, I've done this, this, and this, and this, and there's no possibility here in my design for the reviewers, there's no possibility that something could have gone wrong with this because we've taken all these robust steps. It's all in the consort agreement. If you do all of those things, then you've got a much better quality trial that's perceived to be better quality. So having a central coordinating center to do that is much better. Randomization has some difficulties. If it's drug A versus drug B, it's usually relatively easy. If it's drug versus placebo, that's more challenging because patients don't like the idea of being on placebo for anything serious. If it's surgery versus no surgery, you've got a real problem, but people have found ways around that. And getting patient consent, patients always want best treatment, so they say, especially in Asia, I found, well, doctor, what's best for me? And you have to say, well, I think it might be this, but I honestly don't know, and if we don't do this trial, we'll never find out. So, I think the best thing is, if you don't mind, help us find out for the future. Some people like that, most people don't. And the answer, we'll come on to this about small trials. Actually, I won't talk about this because I'm sure Thuy is going to raise this point about the dangers of doing dangers of observational evidence and small trials. So the other thing, randomized double-blind placebo-controlled trial sounds like the best. So if you can throw in blinding as well, that stops, it reduces the possibility of bias of interpreting symptoms of science. So this is when the patient's in the trial. If the nurse, the doctor, the researcher, everybody's looking after the patient, and the patient themselves don't know what treatment they're on, there's no possibility of bias creeping in, of adjusting the other treatments to support it. So blinding, especially double-blind, is great. So blinding aims to reduce the possibility of bias. It's a long sentence, you get confused. Yeah. Open label, single blind, double blind, we can skip that. Okay. So drug trials often double blind using a placebo. The problem is placebos, they may sound simple, but actually it's very difficult to do a placebo. To find a placebo that works, because very often treatments can be unmasked by the taste or the side effects. For example, I did a trial of hydroxychloroquine for immune activation in HIV. It cost me 2 years of my life, actually more than that, 5 years of my life to get it done. And one of the big problems was how to do it. It needed to be placebo controlled. So the problem with hydroxychloroquine is like, many probably familiar with chloroquine, right? The same thing, it's a very bitter taste, right? So getting a placebo that's got a bitter taste is quite difficult. In the end, we had to basically mash up the hydroxychloroquine and put it in a capsule, and then people could swallow it without detecting the taste. Another thing is side effects may unblind a trial, so we did a placebo-controlled trial of thalidomide. This is years ago when people were worried about HIV wasting. And then thalidomide, has this bad reputation. It's a TNF blocker, but it was obviously marketed as a sedative in the 60s and led to all of those problems with congenital malformations. But you could tell the people in the clinic who were on the thalidomide and who was on the placebo, because in the waiting room you could see half the people asleep in the corner and the others were, when's my appointment coming? When's my appointment? So the people on the thalidomide were unblinded because of the somnolence associated with the drug, right? So actually getting a placebo blinding, there's all sorts of problems with it, and it's actually incredibly expensive, because if you get a pharmacy, if you want a company to make you placebo, they have to stop their production line of that drug in order to make your placebo that looks the same and put lactose in or whatever. So it's like downtime on their production line. There are specialized companies that do this, but usually you're looking at a placebo. If you're looking at generic drugs and whatever, the placebo cost will be probably 10 times what your generic is. So some issues with placebo. Study population, defining the patient population is really important. So here we've got efficacy versus effectiveness. So for an efficacy trial, this is about really showing whether your drug works in a select population. You're really trying to get a clear idea of whether this works definitively. So you have very tight criteria. You exclude anybody who might not benefit from that, anybody with other comorbidities and whatever. But versus an effectiveness trial, which is you want kind of later on in the stage of development where you're trying to see whether this works in the real population, where you want then criteria to be as broad and as generalizable as possible. And you can see this play out in a lot of HIV trials. You know, those of you came to the talk, or you probably know the study yesterday anyway, whenever it's 2 days ago, I gave a talk about the Dawning trial. It's a great trial from a pharma perspective. It's just an example, but they excluded, it's a second-line trial, and they insisted on resistance testing, and they excluded people who had cross-resistant, who had no available second-line nucleosides that were fully active, right? Which makes it non-generalizable to the general population that need that intervention, right? So it was great for a pharma trial to design it in that very tight way, absolutely hopeless for program settings. So that was different to an efficacy trial where they wanted to prove that dolutegravir was better versus something that was useful in real life. Okay, we're nearly there. Outcomes. You've got to define the outcome parameters. Now, I'm sure you all know the way that people used to cheat in clinical trials. Not cheat, you know, we all investigate, we put a lot of effort in, we want to get an answer which is meaningful. So the easy way to do it is to measure 20 things, and then by chance, one of those will come up with a p-value less than 0.05. Now, if you are unscrupulous or just highly motivated investigator, the temptation is to say, well, that was the thing I was really looking for, and you know, I've shown it's positive on this thing. So we can't do that anymore. We should never have done it. We can't do it anymore because you have to declare up front what is the main thing that you're going to judge your treatment on. You choose a primary outcome parameter, and then the safety net is you have to put that on clinicaltrials.gov. You have to declare what's your primary outcome, and woe betide you if you try and change that halfway through the trial. That raises all sorts of red flags. So it's important to choose a primary outcome, and you have to choose the best one. That takes a lot of thought, but it doesn't stop you measuring other things. In fact, you should measure all sorts of other things in a clinical trial. You don't just want to get that one answer, maybe two. We'll talk about this. A trial is an opportunity to get all sorts of other scientific information about something. So, for example, the START trial tested whether it was better to start antiretroviral therapy early or to defer it till the C4 count fell below 500. That was an important question to answer. They could have just done that. It would have been 4,600 patients to answer that question, a lot of effort. But they chose to answer what's the effect of early antiretroviral therapy on lung function, on cardiovascular function, on renal function. They did all of these studies to get additional scientific information, biomarker studies and so on and so on. So you can define all sorts of other outcome parameters. You just have to choose one that's the most important, and you'll stick to judging. Nearly there. Sample size analysis plan. You can do a sample size calculation yourself. There are online calculators. It's actually not very difficult. The statistics around a clinical trial, you know, you spend years doing this, and actually it usually comes down to a 2x2 table and a chi-squared test, which is like the noddy test that anybody, you know, in the first lesson of a statistics course, I can't remember how to do it, but you know, it's the first thing you get taught. It's actually the statistics generally very simple, and the sample size is not very difficult. You just plug a few things to calculate. So you can get a rough idea of the thing, but you must always check it with a statistician because, you know, remember the rocket can go wrong. One of the things that can go wrong is you get the sample size wrong. That's a lot of work down the drain. So, and you need a statistician involved in the study design. So statisticians are friendly. They're delighted to get involved from the beginning of a trial in the design stage. Few people ask them at that stage, but you should do so. When I review grants for clinical trials, the first thing I look for is there a statistician as part of the trial team? If there isn't, I reject it with a few caveats. But it's the difference between a good trial and a risky trial that might go wrong is whether there's a statistician who's really looked at it from the beginning and make sure it's methodologically robust. So it's really important get a statistician involved. There we go. And then lastly, ethical, feasible, financially viable. Those are all important. They come in. So whatever you're designing, whichever shape this goes into, you've got to bear those things in mind, because you can have the greatest study in the world, but if it's it's not going to get past an ethics committee, or more fundamentally, it's not just whether you can get it past a committee, it's whether it is ethical or not, and there are complex issues around that. It's always good to write an ethical justification for the trial, whether it's feasible and whether you can get money to do it. There we go. So I go back to the question I posed originally, see whether any of you change your mind. Annette, the senior rabble-rouser voter. So the intention, about this first one, defining the exact characteristics of the trial participants. Who thinks that's always important, designing trial? You can vote either way now. So if you think it's important, is green. If I've convinced you that's not always, you don't have to always define the exact characteristics of trial participants, show your red card. 1, 2, 3, please raise your hand now, the green. You still think it's always important? Yeah? Okay. So what I was trying to get at here, so defining the exact characteristics.
You have multiple choice. I mean, you have multiple answers, correct? Or you have to have only one answer?
Oh well, it's always important. Actually, they're all trick questions. They're all trick questions. So this goes back to efficacy versus effectiveness, right? So you do have the option of actually Yes, you do have to define exactly, but you can include vagueness in that to make it generalizable, right? So it can just be, for example, trial I'm doing at the moment, we say uncontrolled diabetes. Everybody says, what's the HbA1c? What's the glucose? And we say, up to you. It's a clinical judgment call, right? Because we want it to be an effectiveness trial. It's what the physician thinks and thinks. So you don't have to. It doesn't have to be that exact. You have to define everything, but it doesn't have to be exact. So that was the point of that one. Deciding on only one outcome to measure. Any advance on that? So we've got 3 red cards. Okay, great. So the reason that's there is, yes, you need a primary outcome, but it's a waste if you do a trial without looking at everything else you can possibly get out of it. So that's why that one's not always necessary. Including either an active or a placebo control group. Okay, we've got no reds there. What was I thinking here? Including either an active or a placebo control group. No, the reason that is wrong is you can, actually I didn't cover this in the talk. So you can have deferred, right? So the START trial had no active or placebo. The control group was deferred therapy, right? So it doesn't always have to be. You can come up with strategies, right, to do that. So that's not it. Using an online sample size calculator to estimate sample size precisely, always important. We've got the red card. Okay, very good. So no, you need a statistician to help you with that. You don't always do it. And then taking time to consider thoroughly all alternative design parameters. Got some green cards, yes. Okay, so excellent. So the biggest show, that's the point I want to get across. If you're doing a randomized controlled trial, you've got to spend the time thinking about all these design things. It's no good back of an envelope and off you go. It's months of considering what's the impact of this bulges out, push that back. And you need to talk to all sorts of people to make sure when you launch that rocket, you've really got the optimal design that's going to answer the question you want. Okay, so I think that was, there we go, there's the answer. Last point. Ultimately, the key to success in a randomized controlled trial is, 1, having a good idea, having lots of money, being able to survive on 6 hours sleep per day, or something else. Okay, first one, having a good idea. I think that's important, yeah. Having lots of money, that's definitely important. Yeah, I see the green cards coming up. Being able to survive on 6 hours sleep per day, that's wrong. You need to survive on 4. Or is it something else? And actually it's something else. Ultimately, the key to success in a randomized controlled trial is collaboration. You cannot, to do a good trial, you need to work with other people, work as a team. if you're going to do anything substantive, you need to work with people outside of your own clinical practice so you can build up the numbers to do it. Collaboration, learning how to collaborate is the absolute key to success, persuading people to work with you. All right, so, this is the last thing. So I didn't mention this. The other thing is, people don't realize this sometimes, but to do a randomized controlled trial, do a substantive trial, you need a huge organizational structure of various committees, a data safety monitoring board, a trial steering committee, various laboratory cores and statistics cores, and a trial implementation group, and working with the sites. This is actually a real trial. This is a real trial organizational structure. It's a TB trial I'm doing at the moment. It's a bit of a nightmare, and you can see why from this slide. But you know, it just is a huge operational undertaking. So why bother with all that? And it's really essentially doing a randomized controlled trial provides the most rigorous clinical evidence. It changes clinical practice, and in the long run, they're highly cost effective. So it's worth, you know, if you've got the stamina, you're interested, I would strongly encourage you to think about learning or doing randomized controlled trials. You can't do too many of them in a career because they each take a lot of effort and a lot of time. But one, if I were to give up all of the willingly give up all of the observational small studies I've ever done for one randomized controlled trial without a shadow of a doubt. So it's worth it in the long run. So here we go. Now we're on to the discussion. Well, I'll let Thuy, who's been sitting very patiently for me to get to this point. So we'll have some discussion now. So a small trial doesn't need all of this, surely. So we're going to discuss, you know, maybe for you, maybe doing this huge randomized controlled trial, you know, the big things, maybe you are ready to do that. Maybe you want to do that. Is it worth thinking about starting small? So let's discuss that point.
Oh, it's very nice. Thank you very much. Well, very nice, Nick. I don't have very much to add to that. I'm learning from you. As you know, the only reason I signed up for this is that I want to learn from you. So,
Thuy has, if you don't know, has run an amazing. I can't even know. I used to call penicillin Mon-FEI, and I can't remember the new name of it. Talamycosis. Amazing trial in Vietnam, multiple centers. It was brilliantly designed, and as with good, you know, well-designed trials, well conducted, it got into the New England Journal of Medicine. So you have, and there aren't too many investigator-initiated trials that get that far. It's usually pharma stuff because they've got the resources to do it. So you've got loads of experience too in how to implement and design a trial. So don't be too modest, Thuy.
Wow. Nick, it was you who was the head of the trial steering committees that helped
we can just have
getting that.
Yeah, okay.
So I guess the question that we want to go next is, now that you know what it takes to do a proper randomized controlled trial, and the question is, how do you get started as a young investigator? How do you get into this career of doing a clinical trial? That's the question. And you know, Nick and I debate this, then whether you could, the question is whether you as a clinician see in a clinical dilemma in your practice that you think is not solved by guidelines or by treatment guidelines out there, and you struggle with and you want to test. And that's really, this is an example that we had in China last week. Given the example, just to be very specific, so for telomycosis treatment, you know, we did this trial that required 500 patients, and it took me 7 years to conduct. But in China, people wanted to ask the questions whether we can use voriconazole as opposed to amphotericin B. So that is a clinical trial question. Ampho B has a lot of side effects, and in China, you know, across all the hospitals that I've been to, they said that Ampho B made in China is very toxic, and most patients cannot even tolerate it. And in our trial, we found that Ampho B was superior to itraconazole. So the question, you know, they want to ask is whether voriconazole would be a reasonable alternative. So it's very, very decent clinical question. They actually are doing that in their clinical practice. They are using voriconazole when the patient cannot tolerate it, but there's no data of efficacy. So here you go. Dr. Lee, sitting over there, she wanted to do this trial comparing amphoB and voriconazole. That's what they do in practice right now. But you don't know what the relative efficacy is. Can you do a clinical trial on that? So we sat down and go through the entire process. Not the entire process. We spent hours. One afternoon session, we meant to be 2 hours, end up to be 4 hours, going through sort of the process that Nick just done. Not that comprehensive, but we went through everything. And, we decide going through this process that it would take money, it would take a big sample size calculation to demonstrate now non-inferiority, because amphoB has very good efficacy. So in the trial that we found out, the mortality was 11% compared to 21%. So you got a 10% mortality. You can't really do much better than that for a systemic fungal disease. And so, the trial would have to be a non-inferiority trial. And so to show something, show a very small difference, you require a very big number. So we did some calculations. We have an assumptions of the treatment effect, and the sample size turned out to be nearly 1,000 patients. So there you go. It will take 1,000 patient, few years study, and then as you go through this process, it will take, huge undertaking. And she got $150,000. That's not gonna cut. So there you go. That's the process. So the question for us is, and Nick will have his side, but whether a small clinical trial worth your time. My take on it would be, depends on what question you want to ask. If you want to answer a definitive question like Dr. Lee, she wants to know whether voriconazole can be as effective as amphoB. That is a very definitive, confirmatory question for, to actually inform treatment for clinician. If that's your goal, that's a big clinical trial that Nick talked about, phase 4, phase 3, phase 4 type, definitive trial. If you want to do a trial because there's no prior treatment and you want to establish feasibility, whether you can do this, just the proof of concept that drug, for example, steroid would work in this condition. You've used it, you want the proof of concept that would add some additional benefit, for example, and you just want feasibility, whether you can do this, then there's a place for that called feasibility trial. And the whole purpose is not to be confirmatory, but to give you an idea of a treatment effect so that you can design a confirmatory trial to definitively answer that, but based on the preliminary effects that you come to with this small sample size. Or small sample size that Nick mentioned, phase 1, phase 2, based on FDA sort of terminology, is toxicity safety study. You just wanted to try a new drugs in a new condition to assess safety but not efficacy. Then you can do a small trial. So that's my take. And we will argue about this, but I think that to be involved in a clinical trial as a junior investigator and thinking that you can run a clinical trial definitively, just think about all these steps that Nick just talked about. It's huge. It costs money, and you have to think how your result will translate into practice. Your finding, how is it going to be translated? How is it going to change practice? If what you find is not going to make any difference or not going to influence treatment outcome, then is it worth your 7 years of work? 7 years to publish one trial, even though our trial was lucky enough to make to the New England Journal, and we have a lot going on, but you could have a negative trial. You could find no difference in the effect, and it's not going to make New England, it's not going to change clinical practice, and it's going to make it low journal. It's basically a 7 to 10 years sort of work. So you have to decide on that, and that's why we built in the sub-studies, components for this talk. Just how you get started as a young investigator, understanding the process of clinical research and running clinical trial. And my take would be sub-studies would be the best way for a young investigator to get started. So there you go. Nick, your take on it.
Sure. Thanks, Thuy. So just I'll pick up on a few things, and then maybe we can get some feedback from the floor. If anybody's got any questions to ask on this. So what Thuy's spoken about, and I guess the process that I've shown you is like what you need to do a definitive large-scale randomized controlled trial. And the slide is a small trial doesn't need all of this. Can the question is, as a junior investigator, if you're interested in getting into clinical trials, you want to actually make an impact in your career on a big scale, then you should be thinking about doing randomized controlled trials. But obviously, if you haven't done one before, it will be a big challenge to go that leap, and also you need backers in terms of funding, and it's quite hard to do that from nothing to scratch. So if you want to do that, there's going to be something. Thuy said sub-studies, which are a good idea to take a trial that's ongoing already, and then come up with a question and work with that existing trial infrastructure to do something, and you can get involved in the process that way. I would actually advocate that it is worth. You can do meaningful small trials. So I'll tell you how I started in clinical trials. So it was when I was doing my MD, and at that time, as I alluded to earlier, there was interest in wasting, HIV wasting, because people were getting thin. It was in the days of all the opportunistic infections without too much effective antiretroviral therapy around. So I was interested in wasting, and this company called Serono produced growth hormone, human growth hormone, which they're giving for chronic wasting. And I thought, well, okay, I could do a small trial with this, with patients at the time they had opportunistic infection, because that's when people lose weight, when they're sick and in hospital with that. So, and the key to that was it was not looking at a mortality change. It wasn't looking at improved clinical outcomes. It was looking at a biomarker, an intermediate biomarker of metabolism around protein metabolism. Could we switch off the destruction of body protein? And there were biomarkers we could measure for that. And in the process of doing that, it's an important question. Here was a product that had been licensed for use in chronic wasting. And it was like, could we just give a short course of this very expensive drug at the time when people were losing weight? And that was the question. And we built a trial around that. It was a relatively simple trial design, but in the process of that, it meant working with the pharmaceutical company who owned this product, interacting with their statisticians, interacting with the with a team of experienced people, and reading a lot. And you have to write a protocol on getting it not backed and so on. In that process, I thought, actually, this is quite fun, because at the end of it, after a year of designing this wretched thing, I actually had learned so much about how to write a proper protocol, how to design a trial, and then implementing it was actually relatively straightforward. And then it gave an answer, and we sent it to New England Journal. Of course, they rejected it, but they gave us nice reviews. It got the sort of feeling that had it just been a bit larger, it would have got in. And the reason it was that, because the question was right. It was a relevant question for that time, with a product that people were thinking about using. So that was a good experience in a small trial, and then that sort of got me thinking about other simple clinical things. So it went from I did 3 or 4 small trials like that, all of which got into reasonable journals, and then I kind of thought, okay, we need bigger scale, and I moved to a unit which specialised in the UK in doing large scale trials. And then, all the tools were in place. All I've shown you, I knew how to design a protocol. It was then just a matter of expanding that, with a coordinating center that could handle multiple sites, and with ideas that could get millions of dollars to actually support them. So I would actually advocate that you can do small trials. It's just a matter of thinking about a meaningful question, and discussing that with people and your colleagues. To just refine that question and make sure it's something that people haven't done before, or if they have done before, there's a spin to it that's unique, either in your particularly in your setting, or you're taking advantage of some particular patient characteristics in your setting. You need to leverage off some advantage that you've got so that you can do a small-scale trial that people are going to say, yes, that's answering an important question. It may not be a 900-patient trial that gets into New England Journal. New England Journal, Lancet do publish small-scale trials, and they also do publish negative trials. Most clinical trials, this is another health warning if you want a clear career in clinical trials. You spend probably on average 5 years for a big trial, 7 years. For example, the Earnest trial, idea was 2006, started 2009, so it's now 12 years since the Earnest trial concept came, and we're still writing the paper. So it takes an eternity. So you do need patience to do it. Patience, as in the being prepared for a long wait for the answers. But I think a small trial can happen faster. It can perhaps be a bit more rewarding. And as I was saying, you can get small trials into high impact journals, even if they're negative, as long as the question is solid. It's a good question, and people say, yes, this is a question we want to be answered, even if the answer is no. It's frustrating if you spend 7 years of your life to get a negative trial, but it's still an important contribution to practice. So, for example, the example I gave before was this hydroxychloroquine trial. We were trying to look at whether hydroxychloroquine could decrease immune activation and slow down the decline of CD4 cells, and maybe delay the start of antiretroviral therapy. The hypothesis was completely wrong. It did the opposite. So it was a negative. It was not only was a negative trial, it was like double negative, went in the wrong direction. But we still got it published in JAMA, and the reason was that people were interested in that question. There were in vitro studies. I can't remember the name of the Italian very famous immunologist who published in the top hematology immunology journal, saying basically hydroxychloroquine does fantastic things for HIV immune activation, in vitro study, uncontrolled, and then we could come out with a definitive randomized controlled trial. It was only 88 patients in the end, but it definitively answered that question, and it stopped people prescribing or thinking about prescribing hydroxychloroquine for ART naive patients to slow decline. People still wanted to then do a trial in people on antiretroviral therapy, and they did the same trial. It was again negative, but sometimes it's just important to address these ideas and knock them away. So even negative trials are important. The key thing is the question meaningful, and is it going to last the duration of your trial? Is it still going to be meaningful in 5 years when you've completed your trial? That's another catch.
So just a few things I pick up on that, and then I'll leave for the audience to ask questions before we end with sub-study. We have about 10 minutes, right? 5 minutes. So I just want to pick up a few things on what Nick said. One being that we don't discourage you from starting a small trial, but I clearly, from what Nick said, you have to have a very good clinical questions and understand that utility of your research, how is it going to answer, is going to help. So that require speaking with more senior people who had a lot of experience on this, and ask questions and get advice. Don't do this alone. Certainly don't try to launch a rocket alone. And small or large, they're a rocket launching business. So talk to people. Another thing is that to run a clinical trial, it's really important to have this institution support, this all facility. The reason I was able to be the PI and run this trial was because I was with the Oxford University Clinical Research Unit. They've run trial for 20 years, run really definitive trial for 20 years with the experience, with capacity, and all that infrastructure is in place. Without that, it's nearly impossible to do for just starting out as a clinician in the hospital. It's very difficult for the definitive trial. So those are the few points I want to pick up. So any question before we sort of end with the sub-studies topic? Any question from the audience? Any at all? Yes?
This strikes me as a researcher. I've been mostly a qualitative researcher and not in the area of HIV, but that some of the questions which are being asked, particularly where the evidence is quite well known, but we're unable to translate that into practice. That some of and if you're looking to start as a researcher, and I think there are qualitative questions to be asked as well. I know that's not the topic of your presentation, but smaller studies to get yourself into the process with interviews of, I say, for example, questions coming to my mind, transgender patients and their access to HIV was coming up, and you're unable to reach them to achieve. What are the barriers for them to achieving treatment? Studies, interviews, for example.
Yeah, as you say, so this is more about randomized controlled trials, but I think the relevance of that is in preparation for a randomized controlled trial. You've got to do all of that groundwork to understand, are people going to accept to enroll in this trial? What, as I mentioned earlier, about the complex interventions, what else do you need to do? What's the background to make that work? So I think that's all really important. Before launching into trial, you may actually need to do some qualitative research to understand the patient's wishes. So one thing, it's a dreadful omission actually from my slide. I can't believe I did this, but actually having community discussions as well about the trial is critically important. So before I've done, before you launch into any large trial, making sure that the community supports that. So having a community person. Now the community organizations have advisory boards. They're set up and they're willing to review trial protocols, right? You can get incredibly useful feedback from that. So there's nothing other than discussing with senior colleagues. Actually find a community representative who can feed that into an experienced community advisory board to get feedback on whether that trial's a worthwhile thing to do from a community perspective. It can make a huge difference having community support, especially if things change and the trial is becomes controversial, and making sure you've got the questions right. So all the preliminary work about understanding what patients want and what the barriers are to recruitment and so on, but also discussing with the community, really important.
Any other question before we... Any other questions? Okay, I just wanted to end with the ideas of how to add sub-study to clinical trial. As a young investigator, my advisor would be to start your career, if you want to do clinical trial, working with senior people like Nick, people who know how to do this very well, come and learn from them and actually try to add sub-study to trial that they are planning. And this is a huge benefit. You add a lot of scientific benefit to the trial, but also your career. Because running a trial, as we just talked about, takes so much time and all these clinical information that you're going to be collecting. So there's a lot of opportunity to build in sub-studies for your career, but also to help answering the question. So sub-studies are different categories. So one could be you can design something to understand the mechanisms of the effect. So certainly a lot of clinical trial answer question whether treatment A is better than treatment B, but how does that work? How does that work? So think about the mechanism behind that. A lot of trial we can just answer, yes, that's better, but we don't know how that actually works. So think about the mechanism, the process of how that works, and build that in and talk with basic scientists how you're going to do a study, because you got clinical information collected. This is golden opportunity for you to get involved. And then you got sample collected that you can do multiple studies. So I would advise you to build all these in to add scientific value for the trial that answer a definitive question. You can learn so much and tear off as a young investigator. Another way to add sub-study is to, if you're going to have these populations study anyway, anything else you want to add, for example, social study, you want to add about their attitude, their knowledge about this particular disease, add that on. Health economic study, any other disease process, anything that you want to study in more detail, the complication of this of the disease, because you got an opportunity to follow a patient over time. So use that opportunity to your advantage. I think sub-study for young investigator is a golden opportunity to start clinical research career. And a lot of us start out that way. What else? Save sample, if you can build it into your to your clinical trial to collect blood samples, cells, everything you can, and save all leftover blood for potential future research. And you have to build that in and get consent in the upfront. So just a few lines. Any other questions before we close? We have to complete now. It's 8 o'clock. So yeah.
I've just got a quick question.
Microphone.
A fantastic talk. Just validates all my things when I'm thinking I can't take it anymore. That's fantastic. Just a quick question. Is there a particular website that you guys would recommend that we could look at to just see other people's protocols, just to see how they've done study designs, just to kind of get a global kind of picture?
So actually, the top journals now, so New England, Lancet, insist that you submit the protocol with the final manuscript, and they publish that usually as a web appendix. So actually, any trial you're interested in those journals, you can go online and you can access the protocol usually and the statistical analysis plan. So you've got all of the information there. So that's actually a very valuable resource for looking at these things.
I'm going to say this is not going to be one session. I hope in the future, and Netson is here, we continue to discuss clinical trial capacity building. This is not going to be 1 hour that can explain everything in doing clinical trial. We haven't even touched the implementation, regulatory, analysis, and implementation, publication, public engagement. There's a lot of things that we want to continue. We want this to be a topic. This is just to give you an introduction, the flavor, but we hope in future conference we continue this topic in more detail, and even in a small group discussing how do you start with a good research question and designing and actually do some practice and case study. Thank you for your attention.